Connecticut East This Week is supported by SCAD. This September, SCAD is partnering with Philomena's Restaurant of Waterford to promote Sober September. For every mocktail purchase, the proceeds will benefit SCAD's programs, supporting individuals and families on their path to recovery. Visit Philomena's or you can give directly. Learn more and donate at scad.org/ways to give. Hospitals and healthcare are under increasing pressure in the state and across the nation. We talked to Kyle Kramer, CEO of Kimball Health, about how those pressures are even greater for our rural healthcare providers. Plus, we take a look at other stories making the headlines from around the region. This is Connecticut East This Week. Hello, I'm Brian Scott Smith. A day doesn't go by when we don't hear yet another story about the cost of our healthcare or that another provider is reducing or cutting services. Connecticut may be a small state, but it has all the same challenges of larger states when it comes to local hospitals and providing healthcare to our communities. If you live in one of our larger urban areas with easy access to hospitals and care centres, then you're fortunate. But if you live in a more rural area of the state, access to healthcare can be more difficult to get to and may have limits on the types of services that can be provided. It's not a new thing for rural healthcare providers, but it is becoming increasingly more challenging for them. I sat down with Kyle Kramer, CEO of Kimball Health, a healthcare provider in the northeast of the state, to talk more about the state of rural healthcare. Kyle, welcome back to the podcast.
Ryan, it's great to be back and appreciate the opportunity.
So lots of things have happened since we've last spoken to you. The biggest one, of course, is the change in administration here in this country, but also got a new bill that's been brought out by the new administration, which has knock-on effects for many industries, the healthcare industry being one of them. Before we get into all of that, just give the listeners a quick elevator pitch so that they are reminded of exactly your role.
CEO of Kimball Health since the middle of 2020, and hard to believe it's been 5 years since I joined permanently with the team. Very proud to be leading this rural community hospital and have a lot of great things that have occurred over the course of that 5 years, but a lot of challenges that still lie ahead. We've done a great job of navigating the pandemic, working closely with the state for appropriation support of ongoing operations, and obviously now face the daunting challenge of dealing with all that comes with the current administration's One Big Beautiful Bill Act and its rollout.
Let's talk about the fact that you are a rural healthcare provider and what that means, because you're one of the smaller healthcare providers here in the state of Connecticut. Still very, very important, obviously, for the communities that you serve in the northeast of the state. But what in particular are some of the challenges for rural healthcare?
So rural healthcare is largely challenged by, and perhaps more so in other states west of us than here geographically, by distances between facilities, by limited population. But when we bring that back to Connecticut, and especially the northeast corner of Connecticut, we don't have an abundance of public transportation. We don't have large urban access on many levels. And as a result of that, what we find ourselves with is a population that is based in a lot of farm community type activity. And when you have that type of geography, you're dealing with a lot of two-lane roads, a lot of backcountry, if you will, which is part of the charm and uniqueness of Northeast Connecticut. And it's one of the reasons that people love living here. But at the same time, the lack of significant public transportation creates an issue for access. And when we think about rural health in general, there's a couple of things that really jump out. Number one, it's that access piece. How do people get to services on a routine basis? The next becomes equitability of distribution of services. Because of not having a large volume of people who live in the geography, it's a little bit harder to recruit the types of subspecialists to the market that you would routinely see in more urban environments, which again creates the challenge of what services should be distributed in a market like this and what are services that probably should, by virtue of volume and quality maintenance, be transported to another environment. And then finally, it's that concept of affordability. The population that we serve here in Northeast Connecticut is largely federal in nature. By that, I mean that they are insured either by Medicare or Medicaid, and that comprises 70 to 75% of our payer mix, depending upon the month. And when you think about that, and you've got a population that is aging in place, there's a significance of need around certain services, some of which we can very appropriately and conveniently provide locally, and some of which we really do need to send people away for. And for a lot of our elderly population, as well as others, that traveling to other geographies and to larger urban settings for advanced care is a hardship.
Talk to us about your role. You are co-chair of what's called the Rural Healthcare Subcommittee, the Comptroller Sean Scanlon's Healthcare Cabinet. Give us a sense of what that's about. Clearly created for a reason because of the name, the comptroller, you, and obviously other executives and healthcare professionals saw a need. So, what is the purpose of it? And does it come with any powers for you to do anything?
So, in terms of power to do anything, I think the power that I have in my leadership position is really just that. It's leading our task force to identify those issues that are unique and germane to rural communities, to develop concepts and ideas that we can present as potential candidates for legislative intervention to the state of Connecticut, and also to work on strategies that broaden access, improve equitability of distribution, and increase affordability for patients to receive care and for providers to provide that care. We've used that as a platform for the past number of years, and I'm proud to continue my role working with Comptroller Scanlon because it really has given us a voice of being able to highlight the fact that rural hospitals are not the same as your large urban centers. You really cannot paint every hospital with the same brush. There are uniquenesses to the geography. There are uniquenesses to the population. And as a consequence of that, what we have found through developing this cohesive voice around those three primary base tenets is that we're starting to hear legislators recite those types of things back as a part of their speak about healthcare and healthcare access, about its distribution, and about its overall affordability. And that kind of takes us into the whole concept of, while there are significant concerns about what the One Big Beautiful Bill Act could mean on a broader level with regards to Medicaid access, Medicaid beneficiaries who are presently covered who may not be in the future, there is the $50 billion tranche that has been allocated as part of a rural transformation fund. And we're going to be working very closely with other members of the state legislature, as well as the Office of Policy and Management and the Department of Social Services, to develop the application that the state of Connecticut will be submitting to the federal government on this front. And ironically enough, much of the language that is included in the Rural Transformation Fund application process relates back specifically to those three key tenets. And it really is about, how do we improve access? How do we create reasonableness of distribution of services, or equitability, if you will? And then what do we do to enhance affordability of service? And I think the access piece is probably the biggest component. I've long said that in rural geographies, what's perhaps most important is creating access to primary services, and in particular, primary care medicine. Largely speaking, if we can create a system or a construct where we have the ability to incentivize primary care physicians coming out of their medical training programs, or those who are already in practice moving into rural geographies and establishing practice, to do just that, number one, we create a better opportunity for individuals to access their services. Number two, we have the potential to identify chronic disease risk earlier in life and manage against that. And number three, and this is the ultimate goal, is to reduce the likelihood of acute presentation down the road, and recognizing that access and an ability to get from point A to point B in rural geographies is perhaps a little bit more daunting, a little bit more challenging. The earlier we can identify risk potential and then manage against those risks through a variety of means. Number one, primary care. Number two, perhaps leveraging teleconnections, but specifically creating that relationship that goes bidirectionally between provider and patient. We have the ability to hopefully bend the cost curve, lower what it costs to provide care to patients, prohibit patients from advancing acutely on the disease progression continuum, and ultimately manage from the perspective of wellness versus treating people once they become acutely ill.
Talk to us, if you would, about this $50 billion grant program from the federal government. I think that's something that is not that well known. And clearly, even though it sounds like a big number, that soon disappears again. Give us a sense of what it is that Connecticut is going to be looking for, because it's not just Kimball. We do have other rural healthcare here.
We have a committee, a task force that we'll be working with. Part of it is identifying need. Number two is confirming the directions that we've already taken around our approach to rural healthcare in the state of Connecticut, and then expanding upon what that looks like from the standpoint of lives impacted, resources required, and overall cost to support the infrastructure that we really feel is necessary in order to support care for individuals who are in these rural geographies. I think, again, one of the biggest issues and concerns that we have is transportation. To bring it to perspective here, we have a relationship with ambulance companies in our region, but we don't have an unlimited supply of ambulances for transporting patients from here to a higher level of care. And that's not anything different than what exists in other geographies that are truly rural in nature. And when those ambulances take a patient from our facility or another rural facility to a higher level tertiary quaternary center, that takes a resource out of the market. Scarcity of resources means that other people wait for a necessary transport. So medical transport at both a basic life support level and an acute life support level are going to be necessary. So that'll definitely be one of the things that we take into consideration as a part of our efforts. In addition, the concept of primary resources of care and alternative means of providing oversight of patients who are already identified as having chronic disease, whether that be through remote patient monitoring, leveraging novel technologies, whether that be through extending resource teams that are in the community providing care. For example, if we have ambulance teams that are in the community that aren't on a 911 run, are there chronic disease patients that they could check on to make sure that they have A, their medications, B, that they're monitoring their overarching condition? With patients who have asthma or diabetes, are they using their monitoring tools so that they're not developing an acute crisis that might cause them to need to otherwise go to the emergency department? Realistically, what we want to do is provide proactive care so that in the event a patient needs some level of intervention, we're able to do it at a level where it's less invasive and less resource intensive, like it would be if someone comes to an emergency department. So those are some of the big things that we'll be looking at, Brian, but obviously this is still a very new proposition. And, the one thing about the One Big Beautiful Bill Act is it's also a whole lot of pages act that we're still reading through on many levels. And anytime you have legislation of this nature, there's what's written and then there's what's left for interpretation. And that interpretation is what we will be working through as a team.
Talk to us as well about staffing. Medical staff do not come cheap, but also you're in an area where there is less population and possibly less choice as well. And your ability to try and incentivize medical professionals to come to your neck of the woods, as it were, when they may want to go elsewhere. So how do you deal with that staffing situation as well? A lot of burnout in the medical industry.
Very true. And the burnout proposition, I can tell you, is very real. Healthcare has never been anything but hard because we in this country the way the health system is designed, we do a lot of work focusing on individuals at the point at which they have become very ill. And that does take a lot of time, effort, focus, and commitment from your resource team. And your nursing population in particular is such a valuable and recognizable commodity within the industry, but there haven't been as many individuals who have gone into the field of nursing in the last number of years. And as a result, we haven't had as many new graduates coming out of nursing schools as the demand for their services in the market exists. As a consequence, that has placed maybe an undue burden on those nurses that are more seasoned, more experienced. And as a consequence of the challenges of the population becoming more demanding and more knowledgeable, the intensity of the work based upon the types of patients that are presenting, and the scarcity of resources really does put that burnout issue front and center. For us, obviously, what we do quite a bit of is work on how do we retain the team that we have. We have been working with some new strategies around recruitment, have leveraged some folks outside of our organization to help us in that regard to tap into some resource markets that we've not necessarily had access to in the past. We've done a much better job over the course of the last year or so hiring nurses. Where we continue to have challenges is that in a small rural hospital, there are different sets of resources, maybe, not as many support staff that go along with the nurse. It's something that we're working on changing and elevating, because what we want to make sure of is that the experienced nurses we have support resources that make their jobs more manageable. I can't say that it would make their jobs easier because, again, we deal with a very unique population here, and that work does require quite a bit of effort. But to the extent that we can make sure that we have multiple hands who are collaborating with our nursing team, that definitely makes a difference. And the other thing, quite honestly, is that a lot of your nursing or medical professionals really do, when they come out of their training programs, want to be in those academic type environments. Number one, you get a lot of exposure. Number two, you have a lot of volume. And number three, you build a body of experience that makes you far more marketable going elsewhere. And until somebody has gotten that experience, sometimes it's a little less attractive to come to a small and rural market like ours. What I would say is that when we have the privilege and opportunity of capturing individuals who are through with that experience, they've, all right, been there, done that. They've had a few walks around the block and have gotten the blows to the body and everything else that comes along with that type of very intense, highly acute environment experience. They're well prepared to join an organization like ours because, number one, they bring a different perspective to the organization. Number two, they bring a lot of value on a diversified experience basis into the market. And number three, if we can get them after they've had a little bit of that experience, the likelihood of our being able to retain them is a bit higher.
Another interesting facet about Day Kimball, because of where you are placed in the state of Connecticut, you have the Massachusetts and the Rhode Island borders very close to you. Is there a lot of cross-state collaboration? Do you also end up negatively being impacted by that as well? Because maybe you're the closest hospital for somebody who's had an accident outside of Connecticut.
We do pull patients out of southern Massachusetts, western Rhode Island, because especially for the western Rhode Islanders, it's sometimes easier for them to get to Putnam, Connecticut than it is to get into Providence. And the geography just lends itself to that. Massachusetts, we will pull some, but not nearly as much, largely because UMass really isn't that far up the road. Worcester is far, not far, if that makes sense at all. Where we tend to lose to Massachusetts is individuals who want to work in that larger, more academic environment. So we will lose some staff to that environment. However, we have been successful. We've had people who have gone and gotten that experience, but then they come back because they feel more at home here, they feel more supported, and obviously feel more engaged. So we're happy about that. you never want to see someone go, but sometimes you can't come home unless you leave.
As we said at the top of the interview, 5 years you have been the CEO of Day Kimball. What do you see really now as the priorities for you and the healthcare system moving forward? Still, obviously, in this very fragile situation we find ourselves in. And like I said, and healthcare costs being something which never seem to come down in price, but just seem to go up.
It's an interesting question, Brian. You could approach it in a couple of ways. I will say this. With the continuous pressures on healthcare organizations broadly, but in particular on organizations like ours in smaller markets, the ability to provide the right services to support the population remains our focus, but doing so becomes more challenged because we know that Medicare reimbursement is going to be relatively stable. Reimbursement rates for Medicaid in the state of Connecticut are not where we'd like them to be. We're hopeful that over time that's going to change. But if the fragility of the system shifts even further, and with some of the things that have transpired with the One Big Beautiful Bill Act occur, and our commercial payers become more emboldened and pushed for reducing rates that they pay closer to Medicare, then that's going to place the whole system in a very significant level of peril. We obviously have to continue to look at the service mix that we offer. Is it the right mix of services? Is it something that we can support sustainably? Are there things that we do now that may be better delivered in partnership with another larger organization? Are there things that we ought to be doing that we need to double down on and really grow that versus potentially emphasizing or advancing other services? And, and then frankly, our long-term destination and security as an organization is still best manifested as being a partner within a much larger organization.
Kyle Kramer, CEO of Day Kimball Health. Thank you for walking us through the situation that rural healthcare has to look at on an everyday basis. And we wish you and the team success with the federal rural program as well to see what may come out of that when Connecticut puts that forward. Thanks for being on the podcast.
Thank you, Brian.
Time now for a look at other stories making the headlines this week. The United Way of Connecticut released their latest ALICE data recently, showing record-breaking numbers of financial hardship in the state. ALICE stands for Asset Limited Income Constrained But Employed, meaning people and families who are working but despite their incomes still can't make enough to make ends meet when it comes to day-to-day living costs. Daniel Fitzmaurice is with United Way.
When you cut the information about financial hardship just from 2019 till 2023, what we noticed is that strain on households is growing fastest, not in our cities, but it's actually growing fastest in our suburban and rural areas.
The latest ALICE data shows that around 581,000 people in Connecticut are suffering financial hardship. Maura Cook is with United Way of Central and Northeastern Connecticut and said the numbers just keep going up.
Unfortunately, we have reached a record high number of ALICE households in our state at 581,000. From 2012 to 2019, the trend line was very steady, even dipping down and then rising again steadily. But since 2019, we have been breaking records every year and seeing larger incremental increases in the number of ALICE households in Connecticut.
A typical family of 2 adults and 2 children needs an income of $116,000 a year just to live in the state and pay their bills. 55% of the most common jobs in Connecticut, however, pay less than $20 per hour. And Connecticut's minimum wage is currently $16.35 per hour and will increase in January 2026 to $16.94 per hour. Despite Governor Lamont's administration widening the scope for who can get a COVID vaccine booster in the state, disability rights groups in Connecticut are calling on Governor Lamont to follow the lead of Massachusetts and New York regarding who can get them. Both states' governors have signed executive orders that overrule vaccine mandates from the Department of Health and Human Services. Sheldon Tubman is an attorney for Disability Rights Connecticut and says vaccine protection for people with disabilities is just as important now as it was when the COVID pandemic was at its height back in 2021.
Originally, there was a shortage. They were brand new. And so there had to be some kind of system of allocating what the priorities were, basically looking at particularly seniors, but also people with specific medical conditions. And at that time, it was identified that people with IDD tended to be at higher risk. Other kinds of disabilities, so certain medical conditions, diabetes, et cetera, all presented higher risk. And so those people were a priority as well.
The Lamont administration has issued new guidance in the state to make sure everyone has access to the latest COVID vaccines, and in a recent press event made it clear about who should go and get vaccinated.
Anybody over the age of 18, go in that pharmacy, get the COVID vaccine. Anybody under the age of 18, just like it was before, go to your pediatrician, go to your doctor, get the prescription, and go get the vaccine. Vaccines work. They make a difference. And it's not just the COVID vaccine, but it's all vaccines.
All pharmacies in the state, whether national chains or independents, have been authorized to give COVID vaccinations. Most insurance carriers in the state have said they will cover COVID vaccinations, but those working for large companies or whose industry is regulated by the Department of Labor will need to check with their individual insurance carriers to see whether they can get COVID vaccines, as they fall under the current CDC regulations. Members of the US subbase in New London, together with local officials and active and retired members of the Navy, held their annual 9/11 Remembrance Ceremony on Thursday. The commemoration was led by Master Chief Sean DeGraff of the Naval Submarine School, New London.
Today, our New London Navy community comes together with our southeastern Connecticut community to remember this 24th anniversary of the September 11th, 2001 terrorist attacks upon our nation. As we remember that fateful day and reflect on the 2 decades that have passed since, we also retire some worn but no less revered symbols of our nation and our unshakable spirit. We will conduct a special flag retirement ceremony.
A 6-volley gun salute rang out to commemorate these significant moments of the day, as well as the retiring of an American flag. Jackson LaFlash from Groton played a rendition of Amazing Grace at the ceremony on bagpipes, and at age 15 years old said what the event means to him.
I have personally gone to New York multiple times, and then seeing movies that were pre-2001 and seeing the Twin Towers, it's a sight that I wish I could have gotten to see. That unfortunately I couldn't because of what happened.
2,977 people lost their lives in the 9/11 attacks back in 2001. 411 of those were emergency workers who responded to the World Trade Center collapse in New York. Next year, in 2026, will mark 25 years of the terror attacks and will coincide with the 250th anniversary of the birth of the United States of America. And UConn is to rename its new School of Nursing building at its Stores campus in honor of an alumna whose financial gift of $50 million is helping to make the new school a reality. Elizabeth DeLuca, who was married to Fred DeLuca, who created the Subway restaurant chain, made the generous donation, the largest in the school's history. The new school is also receiving $20 million in state funding, as well as other funding from additional philanthropic organizations. DeLuca graduated from UConn back in 1969 with her nursing degree and said the experience of nursing has instilled in her a lifelong appreciation for both the professionalism and compassion that nurses provide. The new school is set to open in 2026 and has already filled its 225 first-year spots from thousands of applications. That's all from us for this edition. Do send us your questions and story ideas to the show via our website at connecticut-east.com or Facebook or Twitter at Connecticut East and on Instagram at Connecticut East This Week. And you can listen to the show again on our social platforms, on demand, and by asking your smart speaker to play Connecticut East This Week podcast. And please like, follow, and share on your social media too. I'm Brian Scott Smith. Thank you for listening.